Good morning. My name is Jera Sloat. I am a CDI specialist here at ABC Co. CDI specialist we will talk about here in a little bit. The title means Clinical Documentation Improvement Specialist. Basically, my job is to improve the documentation process and to try to streamline that for you and for the physicians. So today we will talk about physician queries. Okay, so a physician query allows for a means of communication between the physician and you as the medical coder. The only way for you to code a medical encounter properly is if you have the documentation, not just for billing purposes, but for the legal health record as well. Notice here that I did not say an open line of communication. Queries are to be used for one specific purpose only, and that is to obtain the necessary codes. Ultimately, if you do not know, then ask. However, if you ask, you or I better not know. There are protocols in place that allow for you to obtain answers to questions before we go to the physician, particularly whenever you're, just getting your feet wet here at ABC Co. It is essential to maintaining the integrity of our facility that you use the query process when necessary, but it's equally as important that it's not used when it's not necessary or whenever it's not justified. Of course, as I said before, if you do not know, ask, but make sure that you are following the proper procedures and protocols to asking before we initiate a query or we initiate the process with the physician. Okay, when to initiate a query. Of course, you need to know this. There are a few certain key elements that you should stick in the back of your head as to when a query is justified. We will briefly go over the guidelines. These are outlined by a HEMA regarding when it is appropriate to query a physician. The language that I have included here is directly from a HEMA, copied directly from there. So please, as you're reading these, go through and kind of put them in your words so that they have a chance to stick. So when to initiate a query? When the documentation is conflicting, imprecise, incomplete, illegible, ambiguous, or inconsistent. Pretty self-explanatory. When the documentation describes or is associated with clinical indicators without a definitive relationship to an underlying diagnosis. This right here will get easier and possibly harder as you go through the coding process or as you gain experience coding, because you'll identify a lot of these clinical indicators a lot quicker and a lot easier. But this is definitely something that you should definitely keep in the back of your head, and you will have a lot of questions about, particularly in the beginning. Documentation includes clinical indicators, diagnostic evaluation, and/or treatments not related to a specific condition or procedure. Again, these are things that you will learn and pick up on a lot more as you go, and will be able to more quickly identify them. Documentation provides a diagnosis without underlying clinical validation. Kind of self-explanatory. There has to be validation, not just for billing purposes, but for, again, the legal health record. We have to be able to prove why the encounter took place and the justification behind the treatment or the diagnosis that was given. The documentation is unclear for present on admission indicator assignment. You have to know if the patient was admitted, why they were admitted. You have to know those indicator assignments. So here's just a little overview of what we just discussed. When not to initiate a query. Do not query to question a provider's clinical judgment. Very important. Your relationship with a clinician is incredibly important. You don't want to hinder that. So do not question them over the clinical judgment. Your job is to evaluate the medical documentation in front of you. Do not query when the benefit is strictly for reimbursements. Do not query when there is clinically insignificant findings or irrelevant information. And do not query when the improvement of quality data is negligible. So although There may be times that you are reading a diagnosis or an encounter record, and you can just think of multiple different things that could have been worded differently or could have been included, that generally are, but were not in that encounter. That's okay. You just have to have the reasoning. You just have to have justification for the reason that you are coding what you're coding. Yes, as I said before, a CDI specialist, my sole job is to improve those document processes and to educate not just coders, but clinicians and nurses and the whole field of how we can improve that process. But it's not the job of the coder. You don't have time to go through and mitigate every small aspect of the document. Acceptable queries. Queries can be directed using multiple different formats. We have multiple formats available here. I'm sure that you've seen them. If you haven't, we will let you see them. There's a yes and no format, open-ended styles, but it is preferred to use the multiple choice system. It's kind of across the board that is the most preferred system. It's easier. It streamlines the process a little bit. Verbal queries are acceptable. However, they should be used with mindful concern of the physician's time. Information should be documented immediately following this discussion, ensuring completeness and accuracy. Verbal queries will be rare. There will not be many times that you would have a clinician just near you where you would be able to ask or to clarify that documentation. And in very few cases is it necessary to need that information ASAP. So be mindful that verbal queries can be used, but they are used sparingly. The following information here is a few standards that are required of doing queries, and you probably have heard before or went over, but we just wanted to kind of instill them a little bit more. So a few standards to remember is you cannot lead the physician to respond as you want. So although you might know that the documentation is consistent with sepsis, you may know that, but you cannot lead the physician to tell you that. So the clinical indicators must be included on the query, and that should tell them. That should tell them what the correct diagnosis would be. Always provide the physician with the option to choose other and clinically undetermined, as well as giving them ample space for a short explanation. Organization guidelines require the original query and the response to be inserted into the permanent medical record. So it is required by law that the response be inserted into the permanent record because that's your validation. That's the reason why you code how you code it. Law does not require that the original query go into the permanent record. However, our organization does. I feel like it's best practice. It's not really hurting the organization's organization system or bottom line to just go ahead and keep those. So keep that in mind that you may have been told or instructed before that it's not required to, but here it is. And again, the clinical indicators must be included on the query. So tell them, why you had confusion. Here's the top part of a sample query form. Again, basic information, patient name, medical record, account number. The clinical indicators spot there is kind of what I wanted to highlight here because that is a must. You do not have to copy and paste the whole medical record, but you do have to use the information that you read that was confusing. I shouldn't say confusing, but was caused confusion to you, and put that here so that the physician doesn't have to go back in and search through the whole record and search through 6 pages of documentation when you can simply put 3 small sentences there that can help them distinguish the diagnosis. So here's kind of the middle part of the query form. This is a multiple choice query form. This is sepsis, and we all have known or do know kind of the guidelines regarding sepsis. There are a lot of options here. This works for most physicians, so this is kind of what we stick with. It's a pretty standard form, but notice here in the red that there are, a few different guidelines for the physician to kind of reiterate what it is in a legal definition of a diagnosis. A physician that's been with the organization for many years, diagnosis has changed when it comes to the coding process and when it comes to the legalities of it. So, okay, so now we're going to talk a little bit about my job. So, a clinical documentation improvement specialist are very important roles in multiple different organizations, hospitals, nursing homes, skilled care facilities, through Medicare agency, or I shouldn't say Medicare agencies, through Medicare agency and insurance companies. A lot of places employ clinical document improvement specialists. The sole purpose is to, as I said before, streamline the documentation process. So my job is to make it easier for you, but my job is also to make it easier for the physician and the clinicians while always observing legal guidelines, federal, state laws, organization guidelines. There's multiple different red tape that has to be followed. And so instead of expecting coders and physicians and everybody in between to know those guidelines, that is where I step in. I will say again, as I said before, if you do not know an answer, before you query, ask. And so here at ABC Co, we do have CDI specialists. It's me and another specialist. Some places do not. So, they would be expected to go to their, possibly go to their supervisor. So in the beginning, what I want you guys to focus on is to come to us, and that way you can learn as we've learned. And you can learn not even just the organization, but through little tidbits here and there. You can also be more familiar with state and federal guidelines that you may not have been familiar with before. So it is a great profession. It's great here. So it may be something that you want to look into for further. Okay, well, thank you so much for going through this short training. I hope you have a great day.